panel objectives are pretty straightforward here. Just to become aware of the provider perspectives on the prevention and care of heart disease in South Asian patients, and identify providers' key recommendations for improving heart health care in South Asian patients. No one here has any financial or commercial disclosures within the panel. My only disclosure is that I am a clinician, not a researcher, and this panel experience is going to be limited to the United States practices. I'm very indebted to Dr. Aparna Kalbak and Dr. Anna Kyriakis, as they are the brains and the bronze behind the patient and provider panel presentation, the patient panel presentation that you saw yesterday. I've had the best enjoyment of all of my 42 years at St. Peter's with these two very caring doctors, learning, planning, preparing, and enjoying the company of the wonderful trainees they have groomed. Our high school students, and our students are at that table. Our high school students, Tejas Bogale, Aditi Ajay Kumar, pre-med student, Arushi Ban, medical student, Teja Chandapragara, who's sitting with Dr. Dadani there. Our residents, Dr. Shika Jha, Dr. Andrea Santos, Dr. Geetika Tota, and Dr. Shrishti Sinha, who is awaiting in the wings to enter her residency. They brought a smile to my face every day, as I know they are charged and have taken on the mantle to create better health solutions to meet the needs of our South Asians. And these tomorrow's leaders are the most definite, I feel, are the outcomes of this, not only these panel preparations, but the conference preparation. Here is the panel plan for today. Before I even introduce our speakers, I'm going to share a couple of PowerPoints at the beginning and at the end of the to orient you to our conversation. Most of the hour, though, it will be informal, roundtable, free-spirited conversation between our panelists. Today, I decided that I should explain a little bit about all the things we were talking as providers, because we do have patients, family members, and community members in the audience, and I wanted to make sure that they know what we're talking about when we're talking about prevention. We heard genetics is what it is. It's a non-modifiable problem at this point in time, at least. But we have many other opportunities to prevent disease. So we had somewhat of an endocrine metabolic discussion this morning already. During pregnancy, the impact of programming that happens in a mother's womb will last a lifetime for the baby. So a healthy mother means healthier next generation. And that's what we would term as primordial prevention. Primary prevention is reversing risk factors like obesity, high blood pressure, diabetes before the heart disease begins. Secondary prevention is stopping progression to complications. Tertiary prevention is stopping progression to multi-organ failures, debility, and death. Heart disease does not happen overnight. It takes years to several decades. We have much lead time when we have multiple ways to stop it and reverse it or at least control it. We heard from Dr. Lloyd Jones. Primordial prevention may be even just the best place to start. So we can prevent across various stages of disease process. We can also think about prevention across a lifespan in an individual. um, when they are a child, when they are a teenager, when they are an adult, when they are a senior. Different things may need to be addressed. We can think about prevention across families and generations. Multiple factors come into play along this life course. Some are related to individual exposures, some to individual behaviors, some factors are external or environmental. So as we discuss today, you can think, where in this map is the problem? Where in this map is the opportunity to prevent? Doctors and healthcare providers face many problems. Our trainees found this as they reviewed the literature. Identifying risks early, creating, maintaining practical plan requires much expertise, time, and resources. Barriers can be multiple: patient-related, language, culture, beliefs, insurance, immigration status, family situations, concerns regarding Western medicine, and complex healthcare system, especially in the United States. Day-to-day problems in providers' life are too many to count. While facing the need for someone, the cardiologist example, to prioritize the acutely sick patients in a cardiac care, in intensive settings, and juggling multiple expectations from patients, from family, staff, healthcare systems, to document the medical record, the billing codes, all of those things complicate our lives. Physicians face challenging problems while caring, especially caring for the vulnerable patients with very complex health needs. In 15 minutes visits, this is almost an impossible task to do. And South Asians have unique risks, we heard this all day long, and specific health needs. Limited cultural and linguistic appropriate resources, limited scientific and societal care standards, they're all a problem. Trying to treat an extreme minority population in US with still so many unanswered scientific and clinical questions, and so many controversies about how we think about nutrition to anything else, that how we want to advise patients. It makes it a hard lift for any provider in any system. Individual interactions and clinical care are very complex, time and labor intensive work. Developing culturally appropriate health resources, improving health literacy, and working towards building healthier communities, they're all easy to dream. Something I have dreamed all 40 years. But they are Herculean tasks to execute. So we know there are no easy answers here. Our method for choosing this panel included physician providers who could speak about intervention at different stages of life and health, who valued patient and family-centered care, prioritized modifiable epigenetic risk factors and other social determinants like access to healthy food, medicine, transportation, and healthcare. We were inspired by the fact each of them independently had demonstrated through their work the community level in each of their roles as investigators, as innovative practitioners, as program implementation specialists, and as patient instructors for changing the status quo. That's why they are sitting here. So here you will see one example of how a healthy system or healthcare system in central New Jersey and one nationally known clinician investigator takes on this challenge of addressing South Asian heart health. Despite all constraints of method and time, we have a distinguished panel of providers. I invite you to listen to their lessons learned from their decades of caring experience in various capacities. I would like to introduce our providers on the panel right now. Dr. Nayan Kathari, my own mentor, was supposed to be on the panel, but couldn't be here. But he is a doctor's doctor, teacher's teacher. So anything I am saying or doing comes from his teaching to me. He's more than a father. Dr. Namratha Kandula, she is a professor of medicine and preventive medicine at Feinberg School of Medicine, Northwestern University. Dr. Kandula is internationally known for her research on South Asian American cardiovascular health and a leader in multi-sector community-engaged research to eliminate the unequal burden of cardiovascular disease. She has a long CV and a bio. So I apologize for the abbreviated bios of everyone in the interest of time. She leads large NIH-funded research studies to understand and improve South Asian American health, including the landmark mediators of atherosclerosis in South Asians living in American study, as we all know it as Masala study, and the Saheli and Sa community-based prevention trials. I was so fascinated by her interest in this approach. So I'm very glad she's here. Dr. Kandula is also the recipient of a meritorious K24 Mid-Career Mentoring Grant from the National Institutes of Health, which recognizes her outstanding research and commitment to mentoring students, trainees, and faculty in highly significant science that aligns with community priorities. Thank you for being here, Dr. Kandula. Dr. Ratcliffe. Dr. Alma Ratcliffe is the Vice President and Chief Transformation Officer at St. Peter's Healthcare System. Dr. Ratcliffe oversees all initiatives related to clinical management, resources, and quality standards. She serves as the executive leader for the administrative and business operations of the physician enterprise, and in addition, leads care coordination, social work, pharmacy, population health, culinary, nutrition, and environmental services. Dr. Ratcliffe has over 30 years of progressive executive healthcare leadership experience and served as Chief Executive Officer at St. Clair's before coming to St. Peter's. And now she is with the plans to expand the regional child care services to a tremendous height. So we're all looking forward to that, Dr. Ratcliffe. Dr. Dinesh Singal, he's Medical Director, Cardiac Cath Lab at St. Peter's University Hospital. He's also the founder and president of the Cardiometabolic Institute, which is not only in Somerset, New Jersey, but in many areas in New Jersey. Dr. Dinesh Singal is an interventional cardiologist who completed his medical school from All India Institute of Medical Sciences in New Delhi. We all wanted to go there, by the way. Internal medicine residency at New York Medical College, and cardiovascular fellowship at Michael Reese in Chicago. He did interventional cardiology fellowship at Rochester, University of Rochester. He's a fellow of the American College of Cardiology, American College of Physicians, Society of Cardiac Angiography and Interventions, American Society of Nuclear Cardiology. He has been voted as a top doc by New Jersey Monthly Magazine for several years in a row. He hosts a popular medical radio show twice a month called Heartbeat on 1170 AM for, I think, more than 15 years. Dr. Sunil Parikh is the outreach director at the SKN South Asian Diabetes Center. He is the health navigator and the outreach director in the Department of Medicine at St. Peter's University Hospital. He provides support and access to healthcare and resources for South Asians in New Jersey for over 30 years. Dr. Parikh earned his medical degree in India, went on to earn his certification in public management from Fairleigh Dickinson University. He has decades of leadership experience in healthcare as well as in community service. Dr. Parikh served as the director for the State Commission for the Blind and Visually Impaired, and through that work, he did preventive diabetes work all his life, 24/7, 365, I say. He currently is an expert healthcare navigator, does early detection work at St. Peter's, and he is the best coach in the Central Jersey area for all our South Asians. Thank you.
You know, I kind of, we're taught, we know that at the end of the day, this disease is, what we are doing as cardiologists with diagnosis and the immediate treatment is really managing the mechanical part of trying to open up these vessels, providing an alternative way of blood to flow. But at the end of the day, it's a chemical process, which is what led to the disease in the first place. And if that chemistry is not changed, the disease is going to progress. And so it's really a metabolic disorder. It's really not, what we are seeing is just a manifestation of that change in metabolism. And so they're intertwined. So instead of looking at myself as a cardiologist dealing with that mechanical process, I had to look at myself as someone who has to alter the chemistry, help alter the chemistry in that individual. And that kind of led to the journey of trying to bring the various disciplines together, because I didn't have the capability of being able to provide that care in those 2-3 visits which the patient had. And so that led to, and the other element was that patient who had an event was a captive audience, and they were trusting me as the expert to help them through this journey, not only at that event, the time when that event occurred, but along the way. So if I provided them with the infrastructure to have that multidisciplinary team right where they were coming to us to get their care, I thought that I could make a bigger dent in how the future will be for that individual. And that's kind of what led to the journey. Now that's easier said than done, because that required physical space. From a very practical standpoint, it required physical space, it required the professionals, and then you needed the support system to provide the funding to be able to support that entire infrastructure. And so it's been a journey, but you know, the passion and the desire to make that change has allowed us not only to make that happen, but allowed us to actually grow. And you know, every time I see, and this, you know, I started this about around a long time, but this is around 15 years now, and you can see people who, when I started, who were in the hospital 3 or 4 times within a year, and 10, 15 years out have not been to the hospital again, that with a complicated medical history is so gratifying. And so it's been a challenge, but this is a metabolic disorder which we take care of. So that's kind of a brief synopsis of how this
well, that is music to my ears. I'm an endocrinologist, like to hear the metabolic practice under one stop shop, one roof, where you're giving all the resources in one area. But the South Asians need some specific culturally appropriate resources. And you live in an area of diversity. How do you balance that? How do you make sure that can happen to that patient that way?
So, we happen to live in an area which has a large South Asian community. Being a South Asian, we attract so when I look at, just pick a last name, Del, in our practice, the list, when I have to look for a patient, it's like 15 I have to go through 15, if I didn't know the first name, it would be like 15 pages long. So we have a large South Asian population, and their needs are a little bit more specific. And in large, I mean, some are very common. As we have practiced in our practice, and as I look at it, it's the determinants are three-pronged to make a change. Exercise, healthy nutrition, and a healthy mindset. So dealing with the stressors. So exercise is fairly common. It would be across the board, would be very similar. But where the difference is largely is in the nutrition, because obviously the whole spectrum is different for the South Asian community. And as Dr. Yusuf pointed out, there is still no clarity as to what the right thing to do is. I mean, we know some common determinants. So where the challenge is nutrition and the stressors, which are somewhat different at times within the South Asian population. And obviously there is some genetic component with a higher incidence of lipoprotein little a. So the awareness for as a provider to recognize some of these, we get a lot of patients who come to me for screening because they have a family member or they have a friend who dropped dead and now they're in their 40s, 50s, they otherwise have no symptoms. And for us to scratch the surface and not only identify if they're at high risk, but also to motivate them within the cultural microcosm they live in, obviously is a little bit of a different approach. And so, so one has to be aware that this is a different this is a different ethnicity, and adapt some of the approaches we are using, whether it's having a nutritionist in our team who has that background, and being from that part of the world, we kind of recognize some of the social stressors which they have, and trying to kind of work with them and adapt them to that specific need is one has to work on it.
So not only you have to know it, your team, you have to build them to do this. That's what you're saying. Dr. Kandula has worked a lot on these issues. She is an internist at heart, but a well-known researcher and investigator. You love to work with the community, especially the kind of lifestyle programs that Dr. Singal was talking about. What did you find in your research about South Asians? What were your assumptions? Did anything surprise you in what you found?
Thank you, Dr. Murthy, and thanks to the organizers for inviting me to participate in this conference. I've learned a lot in those last 2 days. So yes, I'm a primary care physician, and I think that the caring for patients is really what brings me a lot of joy and makes my research relevant. And I learn from my patients, and I think about what are the research questions that are important. So I did my residency in primary care at Bellevue Hospital in New York City, which is the city hospital of New York. And I would get called down to the emergency room anytime I was on call, and there would be a young Bangladeshi man or a young, Pakistani woman who was having an MI. And they didn't necessarily fit the pattern that I would think of somebody who would, be at risk for heart disease or a heart attack. So that's the first question, right, that Dr. Gopal started with yesterday is, why is this? But actually what's even more interesting to me is those patients would then be discharged from the hospital and they would follow up in my primary care clinic. And I would tell them, you had this heart attack because you're using chewing tobacco, or you have prediabetes and high blood pressure. And then I would ask them to take a bunch of medications, right? I'm trying to get their blood pressure under control, have them on an aspirin, their blood sugar, and they would come back 3 months later, and guess what? They didn't take their medications. And so that was what really struck me is there is a distance between what we are taught in medical school in our training and what patients are experiencing in their lives. And so my research is about how do we close the distance between us and our patients. And so what I started trying in my clinic, and I had training in this, is asking my patients, well, why do you think you had a heart attack? And the answers would just fascinate me. And so often I would hear, because of the stress that I'm dealing with, because I lost my mother at a very young age, and I never had a role model or the social support that I needed. I'm trying to support so many family members back in Bangladesh, and that's why it's that constant working. We've had people talk to us about discrimination that they faced and how that has affected their health. So it was just recognizing that what they're thinking about their health is not necessarily what I was trained to treat. And so this is what I do in my clinic is I've done research on this. So we've done many qualitative and quantitative studies where we've asked people, what caused your high blood pressure? What caused your heart attack? And then taking those stories and taking those answers and saying, you're an expert in your life story, you're an expert on your health, and let me take my expertise and what I know, and let's bring that together to help you be more healthy. And so that's really what I do with my patients. I ask them that question. How is your health? How do you know? And that is something that I've been able to do from a research perspective, but then implementing in clinical care.
It's commendable. I've seen it in practice a lot. I've had great mentors, but someone who is a researcher doing that just warms my heart. So thank you for that. Dr. Ratcliffe, you have had major responsibilities for major healthcare systems. And currently, you are working on implementing a major expansion of care for underserved population in central New Jersey area. Many are new immigrants in this region. You are from Philippines, considered a Southeast Asian. How does your experience as an immigrant inform your work? What are the challenges that you see in the institution where your experience is coming to your aid or helping you to serve this diverse population better?
Well, first of all, thank you, Dr. Murthy, and thank you again for the organizers of this conference. It's been terrific, and a lot of, I would say, not only involvement, but also a lot of questions, both from the medical professionals and also from lay people. So I'm a first-generation immigrant from the Philippines, and way back when, I was just telling my colleagues here that when I was here, being first generation, and you have young children, the first thing you do is try to get your family from wherever you are to help you out, and which I did. And I brought my aunt. My mom died when I was 10 years old, so my aunt was like my mom, and she really wanted to help. I brought her from the Philippines, brought her here. I have young children at the time to help out. She's diabetic, and she also was hypertensive. 6 months into it, I felt that I was bringing her to the doctor, but despite the medication, she was not getting well. And over time, I think 9 months into it, I was almost afraid for her taking care of my children who were very, very young at the time, and learned that at some point she was not even responding to us. So I then thought that she was not thriving in a country that I brought her in. I thought that people from our countries, from India, would be willing and jump at the opportunity to come to the United States of America. And I was there, and I'm bringing my aunt here, and was really my mother, and she did not thrive. And we took her to the doctor to the point where she was almost catatonic, and I was so afraid because I was having all of these doctors taking care of her. And I decided to go home and bring her back home. And in a couple of months, she was well without changing medications. She did not thrive here. She missed the country. She missed the mahjong. She was playing mahjong all the time with her friends, speaking the language. And you have to remember that when you come here, when you first come as first generation immigrant, you're working. You're working in the morning, you're trying to get things done, and you come home late, and by the time you come home, you're very, very tired, and you've got your children. So there's hardly any interaction, but it didn't dawn on me at the time what impact that is to our parents and to our grandparents who we bring here from the country that they so love. So bringing that to where I am now, and I'm gonna make a point here that the outcome, the patient outcome is really dependent on a lot on the environment, the social determinants that they call, and you've heard this terminology in the past 2 days. The environment, the behavior of the patient, the socioeconomic status of the patient. So the doctor can really only take care of 10% that will contribute to the outcome of the patient. 30% is genetic, so that's 40%. So if you don't take care of the 60%, the outcome of the patient is not going to get any better. So we all have to think of that there's more, and I think Dr. Singal and Dr. Kandula mentioned that it's just more than the medications and what you give them. There's a lot of things that come into play. And bringing that my experience into my work now, I've realized how important it is. So my goal in my career is to make changes, and hopefully in my little world, that saying that if you throw the shell back at the ocean, you're making a difference, and I hope I'll make a difference. Thank you, Dr. Murthy.
You will. Thank you. Dr. Parikh, we haven't forgotten you. You have had an unusual career path. As a physician, you have taken an untraditional route as a public health provider. You have experienced much of the needs of New Jersey population in the prevention and care of blindness. At some point, you have intentionally expanded your work to be a universal navigator for the South Asians, especially those that are underserved. Your work focuses on diabetes prevention and its complication, where heart disease is a major problem. So what was your inspiration to do this? And we know you face a lot of challenges doing your work. Let's talk about only a few of those challenges that top the list for you and the people you take care of.
Thank you, Dr. Murthy. And thanks to SKN Foundation, Eastern Virginia Medical School, and the thing we call ashram in Central Jersey is St. Peter's University Hospital. So the spark occurred on October 10, 1985. I was appointed as a director for diabetic retinopathy screening program through CDC. And I proposed, like I wrote it later, and I said, diabetes can be in 85, leading cause of blindness. So somehow they connected, when I said blindness, then they addressed that later to Commission for the Blind. And the Commission for the Blind's objective is to make blind people independent and rehabilitate them. So untraditionally, I was appointed there to prevent blindness. So I started my mission to remove Commission for the Blind by preventing blindness. So my director accepted that mission. Anyway, you cannot eliminate all blindness. So with that journey, with that spark, a yagna started. The day we did our third eyes training in a special school, and this kid was so irritable, he was so naughty in the room, and we were doing this eyes training in one room. And as soon as we placed a correct lenses on his eyes, his whole behavior changed. The child was visually impaired. So that was just first month. Then second month, I came across, we were doing a diabetic eye screening in Atlantic Medical Center in Atlantic County. And this guy came in and he was bumping around. And we did a dilated eye exam on him. He has proliferative diabetic retinopathy. He had glaucoma. His visual field was less than 40 degrees. Now I'm following up that patient, and in about 3 months, his total life, his family's life, changed. He was on a verge to lose his job. He got the job back. And these are happening like every month. And now I'm learning more about blindness, eye diseases, and then I realized that diabetes is such a leading cause of this visual loss and blindness. On my journey, then I realized I work with a lot of mosques, temples, churches, that our mainly Indian people, South Asians, there's such a high prevalence of diabetes. One time at one temple, 40% of the adults had diabetes. And now on my journey, I came across a lot of South Asian mentors, people who were interested in South Asian projects. And for 13, 14 years, I'm talking them as a volunteer that let's do something about this. And probably in a year, I came across at least 12 to 13,000 South Asian people, going through providing them dilated eye exams. Then we included foot exam, A1C, all different comprehensive screenings began when everybody agreed. And then about 4 or 5 years ago, I got an opportunity and we started this initiative for South Asian people. I needed the mentor, I needed the guidance, I needed the system. There were a lot of complex challenges, but working for 4 years on the same mission with team, with guidance, with technology, and on a platform of a system, we have made those complex barriers a little bit easier. Thank you.
Thank you. Coming back to Dr. Singal, taking it from there, as we meet South Asians, someone like Dr. Parikh needs some expert, guidance and connections. So people need, the outreach director's support. The outreach director needs your support. People bring in lots of myths and misconceptions to the table. So what are some of the key ones and how do you deal with it?
That's so true. No matter what the level of education a person may have, especially if they're not in the medical field, the thing which I find when I'm with a patient in the room is more often than not, we as physicians, and we're sitting here, we're talking, there's a lot of, I was told 30 to 40% of the audience is lay people. And one of the challenges is how do we translate what we have learned into simple language which they can understand. And just because someone's a PhD or an IT professional, we have a lot of them in this community, we sometimes may take it for granted that whatever we are saying or however we are explaining it, that it's obvious to them. But that's not true. So you really have to bring it down to a level which they can follow. So I think whether it's in the office or in the community, you have to use analogies which are simple. So just to give you one example, when I have to sit down and explain to someone the building up of this atherosclerosis and making them aware that what they are eating or drinking, well, eating in large part, can result in that disease process, I use the analogy of a kitchen sink. I tell them, look, just think of your kitchen sink. You're cutting and chopping little vegetables. If you don't have a good strainer, that stuff is going to go downstream, and at some point it's going to plug up. And if it's 20 or 50 or 30% clogged, you won't even know because the water is going to go down. So, and a large chunk of the heart attacks happen to people where there is this 20, 30, 40% plaque, which when they can rupture and cause a heart attack. So for them to understand, and so if you put a strainer, you're actually helping yourself. They get it at that. I mean, whether they're going to walk out and go, whether it's a McDonald's or a Indian restaurant where they're going to, that's a different story, and that's another challenge we have, is knowing and then actually adopting those lifestyles. And we're all in the same boat. We, even as physicians, we may understand, but we may not. But at least getting that message across in a very simplistic manner is extremely important. The other, the issue which came up is when you pointed out that people in certain socioeconomic strata may, or a cultural atmosphere, we may give them the medicine and they may not take it. We don't face that much of a challenge, at least in the patients we take care of. The biggest challenge I face is when I see an individual with, I've done a more detailed lipid analysis, their particle numbers are 2,000, their LDL is 160, they have no symptoms, but they're coming to me for quote-unquote screening, and it's obvious to me that in addition to the lifestyle change, they need a statin. And if I bring it up, the first thing which happens is pushback. I'm not wanting to take a medicine. And the first question I invariably get asked is, if I started, will I have to take it for the rest of my life? And then you have to negotiate. That's where it's not just you can have all this knowledge, you can have all this science, but then if you don't translate into a meaningful way in which the person will take the buy-in. So I figured out a very good strategy now, which works 9 out of 10 times. So I tell them, I said, look, why don't we just do this? Let's do it for 3 months. And let's see what happens. And then you look at the numbers, you're a smart person, you can always stop it because it's going to go back to where it is. It won't go past that point, so you'll be back to square one. And I find that 9 out of 10 times that by the 3 months kind of sounds reasonable to them. And when they come back, as long as they don't have their aches and pains and the LFTs are normal, I have no issue in continuing it. So I think it's as a community, and for primary prevention, our work is cut out because it's not just making people aware, but also helping them adopt. And there you have to use tools, analogies, a little bit of psychology, understanding where they're coming from. And so it's a challenge, we can do all the science we can, and we've known all these things for the last 50 years. But to bring it down to the ground level, we're still struggling, right? So we still are not doing. But it's not partly for what we are not doing, it's partly, the community at large has to accept, the individual has to accept, and we're all in the same boat. I can't blame a patient for resisting. So that's why the challenge of figuring out those ways also is as important as doing the science of what is right and what's wrong.
Absolutely. My medical student asked me.
Can you hear something?
Yeah.
I 100% agree with you. I work with underserved population. Most of them do not have insurance or they are undocumented. So they do follow 3 months advice. Just take it for 3 months. And their A1C comes better or blood pressure goes down. Now the second challenge is for 3 months they had medicine. How about ongoing medications? So that is a huge challenge to get them proper medicine, and now they are putting more and more medicine out, they are more expensive. So that is second challenge I am dealing with. So, and we might talk later on about the resources we find, but that is a big challenge. And some people come with, I take Ayurvedic medicine, I take herbal medicine from India. And it is so difficult So I have to be very sensitive with them about those alternative medicines. Thank you.
Yeah, yeah. One is not wanting to take medication when you don't have a symptom or a problem yet. And the other is a person who is ready to take the medication, but we cannot afford that, or we have to find other resources to find it. True. And our jobs as providers is negotiate all day and on all ends, right? So, Dr. Kandula, we talked about, ability to convince a patient, especially someone who has a different belief, different belief about what heart disease is or what causes it, or how do you get them, what are your skill sets that you use, and what are the ways you teach in your teach your students or in your research, how do you approach it?
Yeah, I think the term negotiation is really important here, and the one difference I would say that maybe all negotiations are like this, but I really try to help my patients feel like they're in control. Because if you take that control away from people, I think you deal with a lot more resistance. So letting them know that, I trust the fact that you know yourself best, and I want to hear your story, and I'm going to take the time to get to know you. And offering them a few different options, as you said, we can try this for 3 months. You want to continue trying, exercise and diet and stress reduction for 3 months, that's fine. I'm going to support you in those decisions. You're the person that's in control. And then let's come back and have a conversation in 3 months and talk about it again and see where your thinking is. So I think time is so important, and people get really frustrated. Primary care doctors are always like, I don't have enough time, I don't have enough time. But if you don't invest that time from the beginning, you're going to feel more frustrated, you're going to start feeling resistance, that relationship, that trust really breaks down. So I try to work with my trainees to tell them, when you walk into that room, just kind of calm yourself down, forget everything else, and remember, this person may have traveled very far to see you. It's you and them in that room, and make them feel like you're really listening to that story, that you really care about them as a whole person. And then get to know them, and then slowly introduce your recommendations. You cannot walk into a room and start telling people what to do. I do have this happen though sometimes, where I'll ask the patient, what do you think we should do about your high blood pressure? And especially with some Asian patients, they're like, well, you're the doctor, tell me what to do. Like, why are you asking me this question? You're the expert, because there's a lot of respect in our community for the physician perspective. And I say that, I do have expertise, I know a lot, but I really want to work with you to make sure that you can do this long term, because you're the person that has to actually do it. So giving them that control, reminding them that they're in charge, and that they, it's their goals that we're trying to achieve, not my goals.
Yeah, absolutely. Spending an hour the first visit, an extra hour, I would say, saves many hours for the rest of your interaction with that patient. And the point you brought up about different people, maybe, I work in the villages in India, and there, if I try to explain, like how I would explain here, they'll say, isn't that your job? Like, why are you giving me your job? Like, just do your job. So we have to know where we are practicing, and at least in New Jersey, most people want explanation and want understanding and want to know why they're doing it. They're a little scientist in their head. So Dr. Parikh brought up the issues with resource limits, where we don't have what we need for the patients, whether it be prescriptions, whether it's language assistance, transportation, all of these things that impair our ability to care for them as providers. So Dr. Ratcliffe, as you run the healthcare system and think of strategies for serving the underserved, how do you address the structural needs that especially a particular population or a subpopulation has?
Yes, thank you, Dr. Murthy. And I also would like to make a comment. I think it was this morning where somebody from the virtual audience asked whether YMCA could help out and what other resources that they can have in order to help out some of these patients. And I would like to mention that here in New Brunswick, we have a family health center located at Howe Lane, and a lot of the doctors actually say, I don't have the time. Dr. Kandula mentioned it, and Dr. Singal mentioned it. I mean, you know, you've got so many patients to see, and you know, you may not have the ability, and although we encourage the doctors to really get to know the patients, sometimes they do need the help. And one of the things that, as an administrator and a physician at the same time, so I do have the resources to help out the doctors and be able to do that, but it could always be replicated somewhere else. So one of the things that we did is, a couple of things, is can we have a screening tool before the patients come in and identify, as long as they're truthful or they can actually begin, where they're going to be screened on some of the way they live, their environment that they're in. In addition, and I said I do have the resources and it may not work for others, but there's health systems, there's organizations out there wherever you are, you live and you work, that you can also have this is a predictive analytics tool. A predictive analytics may not be 100%, it never is, but it can predict, it has a lot of data out there to determine the kind of community that you're living and where the patients are coming from, to the point that some of the predictive analytics now come to zip code +4. I was just handing it down to the block level, and they would know the kind of environment that your patients live in, the kind of, whether they're actually going to the pharmacy to get their prescriptions on a timely basis, whether they're in an environment where there's a lot of violence. So all of that is taken into consideration, whether they have transportation, they have a car, you don't know what's out there. So if you do have that resources, so I'm just using an example in my own role here to help out the providers is to make sure that I have some kind of tool for them to use. So we're now incorporating a predictive analytics. In addition, a screening tool for the patient come in, but it doesn't, and I'd like to emphasize this, it doesn't replace the conversation the doctor will have, as Dr. Kandula had said, with the patient, getting to know them so that they know what they're dealing with. But if I can help the providers have a lot of information up front, then they don't have to go drill down into the details, or maybe they do have to go down to details, but at least they have an overview of that patient. I mean, after all, they have to see a number of patients for that day, and we would like to help out. So in my role is to provide those resources, and I hope that the providers that are here will reach out to the systems that they work with, the organizations that are surrounding them. And I like the idea of one of the virtual callers who said, can the YMCA help? Absolutely they can. And to use the cliche, and it's been used numerous times here in the last 2 days, it does take a village. It's all of us. Thank you.
Thank you. As we approach almost the end, I want you all to think about the most important things you want to share with our audience. What has made the biggest, change? What are the significant recommendations you want them to take home? Based on your experiences, one or two things that you feel that we need to do. So I'll start with Dr. Singal.
Well, that's an important but a very, very broad question. So I'm going to, I guess, think at a macro level. I kind of share what at a micro level we have to do. And I think we probably know, so there's a lot we have to learn on the nutritional end of things as to what's right and what's wrong. So that work is cut out for the scientific community, for the thinkers. You know, we have folks here who are in that pool, but we do know quite a bit. And I think one of the challenges is that when you have a multitude of folks in the whole healthcare system, whether it's a dietitian, a nurse practitioner, a physician assistant, a physician, trying to give advice as to what is the right thing to do, assuming an individual wants that advice, it becomes a big challenge because there are all these kind of controversies. But at least, and then to translate whatever we know so far to something which is easy for the person to adopt, you know, as opposed to giving a lecture on, you know, count the calories and this percentage has to be this carbohydrates, which is important, but for the person to accept that and to practice it when they walk out of this conference room to go pick the meal outside, or when they have to go home and pick the right kind of food from the table, or the bigger thing is, you know, going to a restaurant and then ordering the right stuff. I think if there was a consortium of thinkers, scientists, a non-profit which can have the acceptance and the appropriate recognition as a true and the right entity which people would trust in, just like we have food labels and all. I wonder if, because and this is now going to the South Asian community, because our, you know, a large part of what we have, you know, was already mentioned. When people come here, they may have a certain risk, but as time goes by, the risk increases. And, you know, one of the environment, other than the stresses, one of the environmental factors is in large part nutrition. Maybe exercise obviously plays some degree of role, but and at least from a practical standpoint, that's what I find. I think if we could dumb down things, come up with some sort of system where we could label foods, rate them of their heart healthy rating of some kind, and as a society, if we can get the buy-in of the business community and come up with products which, just like we have, we know smoking is not good, right? So we label it, and at least the individual is making an informed decision when they smoke. Similarly, if they can make an informed decision based on what's in front of them, and it's kind of quasi-labeled on some rating scale, I wonder if that would make some kind of a dent and simplify the process, and not leave it to either a judgment or an assessment that maybe this is right for me or that's wrong for me, or somebody telling them that this is right and that's wrong. Again, that's a work cut out just because we won't have you know, consensus on what's right and wrong, but we know what's, at least to a certain extent. And you know, the exercise piece is important, the counseling. I mean, the work is cut out in many different ways, making people aware, and then the awareness leading to adoption. You know, those are big areas. But I just think if there was a dumbed-down version of what people could follow, and we have a nice label in front of us, would that work? But it has to come from a consortium of respectable thought leaders who are well recognized, and their interest, you know, and then that translates. I don't know. Just a thought. So I'm throwing it out there.
That looks like we need a think tank to work it into a workable, practical solution, but it is very, very important. Especially what you're talking about is every food labeled as heart healthy food or not. How much of them that they can have, and you know, what's a simple way of looking at it? Is it green, orange, or red? So Dr. Kandula has some follow-up response to that, right?
I don't know if it's really a follow-up. I guess you went a little bit to the macro level, and I'm going to go back to the micro level with thinking about my patients. Because you asked sort of what would be my take-home point, and think making sure that they know, whether it's your patient or your community, whether it's your researcher, that I'm with you. I am with you on this journey of your health, and when our patients know that we are with them, we're advocating with them in their communities, we're trying to figure out what is the best option for them, what are the strengths in their family or their community that they can count on, that's when I really see them feeling like they can take charge of their health. So I think giving your patients the message, if I'm going to walk this journey with you, is really important. I'm not better than you, just because you may have a different background. Just making them feel really close to you.
Yes, that relationship. Those relationships carry out a lot that medications cannot do. Absolutely. And having the right team to extend, when you can't always be there, that matters.
Yeah, one of our intervention studies is actually called the SOP study, right? And SOP means together. And that's sort of the way that we've approached the health of our South Asian community, is we do this together. It's not something we do as individuals. It's up to all of us, as you said, to work together as a community to support each other to achieve better health. So I also don't put all the responsibility on myself.
Yeah, absolutely. So building capacity and capability, no one person can take charge of that, and so we do need help. So Dr. Ratcliffe, bringing community to the clinical site and connecting back into the community, what are your messages?
I'm going to go back to just what I said, does take a village. So we all are patients here. I mean, I know you're providers and some are lay people, but I myself, I'm a patient, I'm a statin patient, Dr. Singal, and we all have to take care of ourselves. So to all of us, we need to really look at ourselves and determine, and also our loved ones, and determine how we can help and reach out to them. And it's not just about bringing them to the doctor, but also understanding. I bring back again the immigrant status, because we all here, the South Asians and the Southeast Asians, are very, very similar, and we do have family members that are immigrants. So my message is that bringing them and helping them understand and helping them to thrive in this environment. So I'm not going to go into the details other than it's more than the medications and how we deal. There's always the environment that they live in, the socioeconomic status that they're living in, and thirdly, it's the behavior. And we all are very busy, so we need to take care of some of our loved ones that we brought here from the country that we come from. Secondly is, as I said, patients, and secondly is to the providers who are here. There's help for you. I know a lot of you, and the reason why I say that, because I am responsible, I do have oversight for the physician enterprise and the system that I am at. And everyone always tells me, I can't do what you want me to do. I've got no time to see all of the patients that I need to see. But we do have resources, and for those of you, reach out to your systems, reach out to other organizations, because they may be able to help you understand better the kind of patients and the community that they are serving. And thirdly, some of us here are vendors. And I heard from last night's gala, they are part of the media or part of the pharmacy, and we all have a role. And if we want a better society, especially for the South Asians, and I'm going to include myself there, Southeast Asian, we all have to work together. They do provide with some resources as well, and all of us together, definitely, and I'd like, hopefully, it's not an ideal world, but I guess in our own way, help a better world to live in for all of us, especially many of us here coming from a different country. So my take home is the cliche still works. It does take a village, and we all have a role in it. Thank you.
So I just want to add you know, at a micro level, I do have a couple of observations and things I've learned. One is for a provider, so if there's a physician listening, you know, what I've discovered is a lot of people, especially if they've not had an event, they need a hook in order for them to get motivated to do the right thing. So if you know that this person needs something, find that hook. So if their LDL is 110, but they have a strong family history, the hemoglobin A1C is 6.2, and their regular stress test is normal, and they're feeling fine, they may not be willing to accept the fact that they may need something. So if you feel, if the provider feels, so you know, doing the NMR profile, looking at the particle numbers, and we increasingly have been using coronary calcium scores. If somebody comes back with a coronary calcium score of 500, I find that hook to be able to tell them if that's what I feel. So looking so working with the individual, if they've had an event, the hook is there. So that's easy. But the person who you think is at risk, you need to find the hook. The second thing is for the layperson, if you're after you change your lifestyle and all, and the physician feels that you need a medicine, especially a statin in most cases, don't resist it. That's the other advice. Because as one of my friends, an internist friend, told me, and I use that line all the time now, that either you take this one medicine now, or you take 5 after your heart attack. So I kind of try and not to resist that. I just wanted to.
Thank you. Thank you. So Dr. Parikh, you have the last word. What I would like you to expand on what Dr. Singal said. What are some analogy you give to the people to comply with what they have to do and get the community connected back and forth? What are your effective ways there?
The most important thing, and that is the foundation of our initiative and SKN Foundation's initiative about education. One thing, we have to educate our persons, patients, providers, families, community, and policymakers. So one of the most effective tools I use when I don't call them patients. Anybody can come to our initiative. So I tell them, what kind of car do you drive? And they are South Asians regarding of social status. So I have BMW. Okay, so where do you take that car for oil change? Do you look for a coupon? He says, no, my car goes to the dealership. I make my appointments every 3 months. My oil change appointment is never missed. And I said, that much you are doing for BMW. What is your own body? You missed your last appointment. I was waiting for you. I said, at this institute, the well is coming to the thirsty person. And you miss the appointment. And you know what? As Dr. Kandula said, it builds a trust, a relationship with them. And sometimes while you are educating, coaching them, don't label education. They don't like education. So tell them, we are friends. I'm available to you. Call me anytime. If it is late, text me. Don't wake me up. I do wake up every night 3-4 times from calls from India for post-COVID this happened. Then while all these people have either diabetes or hypertension or MI or whatever it is, if males are coming to the clinic, they don't cook. Their wives cook. So we need to educate the family. So I tell them sometimes, bring your family, let us chat. We will have a cup of tea or coffee. And then their family realizes that this gentleman, Mr. Patel, is coming here to see you for a few times, but I put more salt in his dal every day. And he never told us anything, and now what we should do. So family education is extremely important. And then we have, our initiatives has many events throughout the year where we collect community leaders. And one thing is there, always feed them. If you don't feed them, first pay puja, then education. We put, you saw how healthy food was yesterday morning, this breakfast. So we give them healthy food so they learn it. Also we label it, we have Atul Jain here. So he is our master chef and kind of a diabetes educator too. And we put that for them. So they learn lessons, how much calories, and also they can ask for the recipes. So that way we can educate community. And I wish Thursday we had all these policy makers came to the inauguration. I wish they would have been here today. We need to educate them that look at this conference. We made a huge impact today in this, today and yesterday. It is a historical event for South Asians. So this could be, this conference can be, we can create a template, can be replicated in counties, states, in countries. And this is the way I learned a lot. I didn't know a lot of stuff. And we have so many scholars and 6 months of effort by talents, scholars, organizers, and finances. So this is an opportunity to start, begin our movement to reduce the mortality, morbidity, death rates, and let us become healthier, we South Asians, and there is no better tool than education, awareness, coaching. Thank you.
Thank you, Doctor.
I would just like to add the story of the BMW. There's also this similar story about their pet, their dog, that they would bring into the groomers, and they have surgery, they go, and then they say, I have no insurance, but their dog is groomed every 3 months and had surgery without insurance and would, do everything to take care of that dog. And we end up with saying, how about yourself? So very, very similar. If they don't have a BMW, you can use the dog.
Well, we do have to say, all those South Asians we think of as model minorities, most of patients that Dr. Parikh sees are underserved, uninsured, and so on. So they have higher level of need. They don't all have, it was just an example, right? I don't want people to think all South Asians are educated, all South Asians are rich. That is myth as far as I think about it. So, are we up on time? Okay.